Good evening, everyone. I think we'll go ahead and get started as it looks like people are getting finalized with their logins. I am your host for tonight's exciting AO Fireside series on fracture-related infections. I'm Tom Large at Emory University at Grady Hospital in Atlanta. I have Ashley Levack with me from Loyola University in Chicago, and Jaden Learned from UC Irvine in Orange, California as well. I think everyone will really enjoy the session tonight. These are our disclosures. The AO North America is an independent nonprofit surgical specialty society dedicated to improving the care of patients with musculoskeletal injuries. The AO does not endorse nor promote the use of any product, service, or commercial entity. Equipment used in this course is for demonstration and teaching purposes with the intent to enhance the learning experience. I think the most relevant here for everyone is just to make sure your microphone is muted, and it should be done centrally through the folks running the Zoom. You'll see two boxes at the bottom of the Zoom. One is the chat. That is for faculty only. So questions that you have during the session, please put those into the Q&A box on your Zoom menu, and we'll try to get to as many of those as we can. We have 2 to 3 cases to work through. We'll try to do 20 to 30 minutes on each of those. We'll plan to be done at 9:30 Eastern time in the US. This will also include a review of an article by Dr. Brinker from JOT in last year's issues for about 10 minutes. So tonight we're talking about fracture-related infection. First and foremost, we'll talk about how to identify infection, and then think about understanding the factors that we can modify in treating these problems. These could include patient-specific factors, injury factors, and surgeon-related issues. The treatment principles we'll harp on tonight include obtaining appropriate cultures and doing a thorough debridement, obtaining stability in a variety of different ways, and having a way to deliver antibiotics both locally and systemically. So with that said, we're going to get right into it. Dr. Levack is going to lead us off with what I've called a ballistic tibia fracture gone awry.
Thanks, Tom. I'm going to share my screen here. Well, I'm really excited to be here tonight talking about infection, something near and dear to my heart. So I'll start off with our first case. And this is a 30-year-old who actually presented to our outpatient clinic. He was initially seen at an outside hospital after he sustained multiple gunshots to the abdomen and the left lower extremity. And at that outside hospital, he underwent an exploratory laparotomy with a colostomy. And the orthopedic surgeon there performed an external fixation of the tibia fracture with a limited debridement of the entry wound. And he was admitted for quite some time at that hospital because of his other non-orthopedic injuries. And he had no signs of compartment syndrome, but they weren't comfortable doing the definitive fixation there. So they actually tried to transfer him to our facility, but he somehow was transferred to jail. And then he presented to our clinic. So
Actually,
here he is.
What do you think about their initial treatment? What would you have done the same? Would you have done anything different if he came in when you were on call the first night?
Yeah, I think typically for this type of injury seen on hospital day 0 or hospital day 1, for me, this is a low energy ballistic injury, and I think it can be definitively treated most of the time in a one-stage fashion, unless you are very concerned about the wound or very concerned about compartment syndrome or vascular injury or something of that nature. So if this patient had come to our hospital initially, I think they would have gotten their definitive treatment earlier, as opposed to an external fixation.
Do you go chasing after those bullet and jacketing fragments there?
That's a sort of a controversial topic. There's no literature out there to say that you have to do that. I think depending on the location of those retained fragments, if they're subcutaneous, if they'll cause discomfort later on, if they're anatomically in a place that's easy to get to and in a position where it could be performed at the same time of your limited debridement. I think it's reasonable to take them out, but certainly there's a wide spectrum of debridements that people have performed for this type of injury. And so while I may have gone after those fragments to perform my debridement, I don't think that everyone would.
James, what do you think? What kind of debridement? This is a small caliber handgun injury, say, centimeter and a half entrance and exit wounds. Are you widely extending those, leaving them alone? How do you approach that?
I think what's interesting to me when I look at this and I hear this history, it's sort of like you're neither doing one or the other, right? In this case, they had an X-fix, so you're sort of leaning in the direction that I don't think this person's ready. There's too much of a soft tissue injury. There's too much risk of infection. There's too many problems to do a pretty straightforward medullary nailing of a tibia. And yet, when you have that philosophy, you'd think you would go and debride it. And I would probably go after a lot of this stuff just because I think it's going to be part of getting the wound clean. I think this looks like it's going to be a place that's symptomatic, and that's going to allow me to then treat this acutely with a nail, like you're suggesting. If you're going to treat this with a nail, then other than the fact that there's more comminution than a typical blunt injury, which is common with ballistic injuries, it's a pretty straightforward tibial injury. It's pretty straightforward to nail this acutely. So I think what's interesting to me is it sort of shows the panic, doing the forensic radiographic interpretation. It shows the panic of the surgeon because they didn't want to open it up and clean it out, but they felt it was so dirty and so risky for infection that they didn't want to put a nail in it. So it just shows kind of a discordant attitude when I look at this X-ray.
So what I'm hearing from both of you is kind of a moderate debridement based on an initial exploration of the wound, a medullary nail, and then would you close the wound or the debridement extensions or leave them open?
Yeah, if I'm performing a moderate debridement and I think I've gotten a clean wound bed, I would close the wound rather than leave it open in the setting of new hardware.
Great. Carry on.
Yeah.
All right. So he presented to my partner's office in the outpatient setting and went to the operating room the next day. He had the X-fix removed, the pin sites were debrided, and again, a limited debridement of the traumatic wound was performed. They performed a tibial nail with the lateral parapatellar approach, and they used some blocking drill bits to help guide the reamer. And then those drill bits were removed towards the end once the interlocking screws were in place. And then he was discharged on postoperative day 1. Unfortunately, on post-op day 12, he came back with increased pain and purulent drainage over the anterior tibia. And he was afebrile, but his inflammatory markers were markedly elevated and his white blood cell count was nearly 20. He actually initially again presented to an outside hospital and was given antibiotics prior to transfer here. At the time, his knee incision was healing well, but you can see the pictures there. He had a draining sinus over the anterior mid tibia, and the previous lateral proximal tibia wound, which was the entry wound, was draining as well.
And this is a new wound, correct, Dr. Levack? This is not the gunshot wound that's now draining.
Correct. Mm-hmm.
What do you think about the displacement on the films there? If we're going to play armchair quarterback here and go back in time, anything that could have been done additionally with the primary surgery to maybe prevent that varus displacement?
Yeah, well, I think, hindsight is 2020. So having seen that there is quite a bit of varus displacement here, I think you can always think about additional fixation to try to prevent that. And, I know that there were drill bits in place used as blocking drill bits and potentially exchanging them for blocking screws, or this nail does accommodate some additional interlocking screws in the proximal segment. And so in hindsight, additional fixation, I think, could have helped the displacement at this point. I don't know that it would have changed his infection outcome though, so.
Any thoughts on why this went into varus, Dr. Learned? Usually proximal tibia fractures go into valgus.
Yeah, it's interesting. So this one, we've got a big comminuted segment. And then if you look at the obliquity, it's sort of the opposite of the ones we typically see going into valgus, where the proximal extent is on the lateral side. And that sort of creates that additional space in the medullary canal for the nail to escape. In the typical fracture, to escape laterally in the distal aspect of the proximal fragment, and that would allow it to drift into valgus. In this case, I think you've got an intact fibula, so that's a lateral strut, and then we've got proximal extent medially, and so the tibia tilts into varus as the nail escapes medially and drops away. And I think that's probably what happened here.
And what would you do with this presentation if this showed up in your, at your 2-week follow-up appointment as far as next steps go?
Well, first I'd clean the vomit, take a good glass of water, because it's like the worst feeling in the world to see these come in after a pretty nice reduction and what you think is going to be straightforward. And so once you sort of gather yourself, then I think for me, then it's obvious, right? So we've got a draining wound, which we'll talk about a little bit later. So I don't think this person needs to go to the lab and get a bunch of markers to make a decision. You might want to get them as a data point. But this person's coming to the hospital, they're going to get admitted, and they're going to be put on the schedule for today or tomorrow so that we can surgically debride this and get going after it.
And with this displacement, are you going to, I thought that the standard of care with an early acute infection is debride and suppress and retain hardware until it's healed. Is that your thought process at this point, or are you going to do anything more different?
Well, I think we use the word debride, and I think that's really easy to get to forget how broad that definition can be. I think with this, we've got probably medullary involvement, and so rinsing out his entry wound or cleaning out this anterior mid tibia wound directly is going to get you some of the debridement, but I think cleaning his canal is going to help you in the long run. So debridement for me in this case is probably going to involve explanting that nail so that I can re-reduce it, and then either putting in something temporary or putting in something coated in antibiotics, going off label, or some other way to sort of augment his fixation with something new that hasn't been bathed in purulence for a few days.
So you're going to open this wound widely, do a aggressive debridement, get good cultures, explant this nail, ream and wash his medullary canal, and then either place an external fixator or a antibiotic impregnated nail.
That's what's happening in my hands. Yep.
Yeah. All right. Let's see what Dr. Levack did.
All right. So I just put this in here to highlight that he did displace into varus, and it's pretty remarkable when you put these two images side by side. So I took him to the operating room, and I did much of what Dr. Learned just said. I did feel that the infection required debridement of the intramedullary canal as well. It was a pretty impressive infection once I opened up the area. And so I removed the nail and took deep cultures from the bone. I also did a anterolateral approach so I could excise those retained ballistic fragments. And there was purulence throughout the metaphyseal comminution and all around the retained metallic fragments. So I think taking those out at this point was a necessity. So after all of the implants had been removed and the foreign bodies had been removed, I did irrigate the fracture and debride the fracture through the exposure that I performed, but then also irrigated and reamed the canal using the reamer irrigator aspirator system. And I felt that I needed to get the fracture out of varus. So I used a medially based X-fix to do that and maintain his alignment while I placed an antibiotic intramedullary rod just for local antibiotic delivery. I used empirically vancomycin and tobramycin in that while I was awaiting culture data.
So the RIA, for folks who may not know, is a reamer irrigator aspirator. So it's a kind of standard reamer, but attached to irrigation and suction tubing. I think of it as kind of power washing the canal. And so instead of just reaming, you're able to kind of suck everything out as you're going, so you aren't, in theory, spreading infection down the canal. If you don't have access to that, my thought would be to make a portal distally as a outlet valve and do your reaming, and then usually just some cystoscopy tubing will fit down the medullary canal from where the nail is, so you can wash everything out in an antegrade fashion. Any different thoughts about that, Dr. Lornan?
No, I like the reamer irrigator aspirator in theory. I've found that it does well with bone chunks and liquid debris. It does not do well with stringy soft tissue stuff that forms after a nail's been in place for a long time. It just clogs. So after my N of 2 or 3 of that happening, I'm starting to understand a pattern. So for something like this, I think it would be a perfect instrument. But I think also just regular reamers and lots of irrigation can be effective here too. Definitely watch for blood loss with the RIA and turn off the suction when you're not actively reaming and irrigating.
Awesome. We will have a little slide later that will have an article from Dr. OH in South Korea about how to make this antibiotic nail pretty easily. This is an Ilizarov strut with one of the eyelets at the top for easy extraction, and usually this is manufactured inside of a chest tube, so pretty straightforward process, but again, an article reference later for those that are interested.
A couple of questions in the chat that I think I don't want to discount them, but we'll talk a little bit about this as we go through that paper about a interlocked antibiotic coated nail as opposed to just an antibiotic nail. So I think we should talk about that. That's a good question. And then amount of Vanc and Tobra in the cement spacer also, we'll talk about that a little bit in the talk about the papers for manufacturing this.
And actually, one last question before we move on. How do you determine what stays and what goes in terms of that comminuted segment in the metaphysis there?
Yeah, so in my first debridement, I just kind of make sure that anything that is retained has some form of soft tissue attachment, because any non-viable bone that's completely denuded of its soft tissue attachments is also denuded of its blood supply and will harbor infection more readily. So that's really my criteria. If there's any soft tissue attached, even if it's a little bit, I'll keep it, at least in the first debridement. And anything that is kind of falling out of the wound, has no soft tissue attachments, that's going to go.
Yeah, it looks like you have kind of a non-segmental defect laterally there. So may not require a full mask delay, but could also add a spacer just as an additional bug bomb if you know you're coming back to this in the near future.
Yeah, and I didn't mention this before, but he did have some anterior compartment necrosis. And so I did have to debride a little bit of muscle from the anterior compartment, which is one of the reasons why I did actually take him back for a second debridement and second look. So this is the x-ray after the second debridement. There was not a lot of new necrosis after that second debridement, but I did exchange the antibiotic rod. Now I had culture data to ensure that I had the appropriate antibiotics in the antibiotic rod, and I did switch them from my first antibiotic rod. And then because he had a sinus tract, I did excise some skin and soft tissue along the anterior aspect of the tibia, which is sort of a tenuous area. And so I had the plastic surgeons come in and evaluate that wound for later coverage before definitive fixation.
So how then do you decide when you're kind of done and ready to move on to something more definitive at this point?
It's a good question. I think it depends on the extent of the infection and how virulent you think the organism is and how good a job that you've done in cleaning it out. After the second debridement, I felt that the wound beds were much cleaner. I didn't see any new purulence. I didn't really see any new necrosis of the muscle. I didn't really have to take any additional bone. So I felt that after the second debridement, that would be the final debridement, and he would be ready for definitive fixation. And then the other thing was coordinating with the plastic surgeons in terms of timing so that his wounds would be able to be covered in a fashion that was that worked for us in terms of getting him covered quickly after definitive fixation.
I know we'll see in a second that we're kind of a team of two managing this case, but if this was just your case moving on definitively, what would be your ideal kind of sequence in terms of coverage, how long to leave the antibiotic nail and X-fix on before moving on to something definitive?
Well, in the setting of an acute infection, I think we got to it pretty quickly. It was an organism that was virulent, but was not a multi-drug resistant organism. It was MSSA. And so I felt that we had a good debridement. We had good antibiotic options. And he had gotten 2 rounds of local antibiotic delivery through the antibiotic nail. So at that point, we were about a week out, and I felt like his wounds were clean and he was ready for definitive fixation. In my hands at that point, I would do another debridement at the time of definitive fixation, sort of a final debridement, take post-debridement cultures. And I would opt in this patient to put a static intramedullary locked nail, but I would probably use some local antibiotic adjuvant with that, either coat the nail in sort of an off-label fashion with PMMA, antibiotic loaded PMMA, or one of the calcium sulfate products, just to provide additional antibiotics at the time of his definitive fixation. And then the ideal scenario in terms of coverage would be to have it done in the same setting, the same anesthetic.
If you use a antibiotic coated nail, is your plan to revise that to a standard nail, or if he heals around it, leave it in forever, or how do you approach that?
Yeah, if he heals around it, I don't think there's a need to revise it, and that would be a win, I think. If you use a calcium sulfate product, that will dissolve, and then it sort of obviates the need to consider removal altogether. So there's a few options out there.
Dr. Learned, anything different? Would you, flap this and let the wound heal let him do 6 weeks of IV antibiotics before converting him to something more definitive, or would you probably proceed with definitive fixation given the kind of acute presentation here?
I'm probably more in the camp of acute infection, aggressive debridement, cement impregnated with antibiotics, and then early conversion back to a definitive non-antibiotic implant or an antibiotic-coated interlock nail or antibiotic calcium sulfate in with using Fragment's technique in with a typical statically interlocked nail. I think the stability out of that and the ability to get a patient who like this has the follow-up that you're going to get is always unpredictable when they're in custody. So having an X-fix gives me the heebie-jeebies in a patient like this.
Great. So taking into account some patient-specific factors as we talked about. Go ahead, Dr. Levat.
That's a wise comment, as you'll see. So after his second debridement, this was actually what his anterior tibial wound looked like. The sinus tract was debrided to a lesser extent at the first debridement, but his skin was extremely friable. And knowing that he would need flap coverage here, and it's in an area that rotational flap coverage is an option, I debrided it a little bit more at the second debridement to get a really healthy appearing skin edge there. That's just his final debridement picture. And then, were you about to ask something, Tom?
No, I was just going to say, is there any role at this point for any intraoperative, fresh frozen specimen to evaluate for ongoing acute inflammation as part of the decision making, or is that not something you typically use?
Yeah, I haven't used the fresh frozen in my practice very much. I actually did not take repeat cultures at the second debridement since I had all 5 cultures growing the same organism from the first debridement, and we had targeted antibiotics at that point. I'd be interested to hear if you two are doing that.
Yeah, I would do the same in this case. I think that's more of a kind of initial debridement if you're not quite sure if the patient doesn't have an obvious fracture-related infection, and you want to get some answers as you're deciding about, definitive revision. Is this an aseptic non-union versus a infected non-union, for example?
Great. So at about 1 week out from his re-presentation, he was definitively fixed by my partner, who did a very similar thing to what we talked about. Took out the external fixator, debrided those pin tracts, took out the antibiotic nail, and re-reamed and performed statically locked intramedullary nailing. You will see here that there are 4 interlocking screws and a blocking screw, as we talked about, just the additional stability in this particular fracture pattern.
And the patient had a flap at the same setting, or was that staged with plastics?
It was in the same setting. Plastics came in after the nail was performed and performed a medial hemisoleus flap and skin graft. So that was performed under the same anesthetic, immediate coverage.
Awesome.
The patient unfortunately refused intravenous antibiotics, and so was transitioned to orals after just the 1 week of intravenous antibiotics in the hospital. He followed up at 4 weeks, still incarcerated. His wounds were healed, no signs of infection at that time. And then I do have follow-up at 4 months. At that point, his flap was healing well. He had no drainage or active signs of infection. He was still having some pain, but at this point, he has not followed up again, and he, I believe, is still incarcerated at this time.
Was he allowed immediate weight bearing after?
Yes.
At this point, yeah.
Mm-hmm. Once the flap had healed, and those are his wounds at final follow-up, which was 4 months.
Do you follow inflammatory markers after their antibiotics to help guide, hardware removal issues if he, progresses to consolidate a little bit more? You just give him a trial off of antibiotics and follow him clinically? Would you, let's take the incarceration off the table here. Would you just take this out after you felt he was healed adequately?
So we do work closely with our infectious disease colleagues, and I know they also obtain inflammatory markers and to help monitor both their antibiotics and that those inflammatory markers are improving. I think if there's concern for ongoing infection or concern for any sort of drainage as he's healing, then the inflammatory markers may be a useful tool, but I think they're hard to interpret sometimes. Certainly they should go down from his initial acute presentation, but I find them hard to interpret, and we'll talk a little bit about that later. In terms of duration of antibiotics, that's another question. You can kind of argue whether or not you need to suppress him until healing or just do a 6-week course. If you think your debridement is good enough and you think you left only viable bone in there that the antibiotics can treat the remaining infection that's present, then I think the initial 6 weeks is appropriate. But if you're concerned that there may be some lingering infection, I think potentially suppressing until healing is an option. So it's sort of a complicated question. I don't know if I have a straightforward answer.
If the ID doc asks you, Dr. Learned, this is your case and you've put the nail in and he's had a flap, and sorry, what was his bug again, Dr. Levat?
MSSA.
MSSA. 6 weeks of IV antibiotics would still be kind of the standard of care, although that's, being studied. Would you suppress this orally? James, would that be your preference until he's healed, or would you be okay with him coming off of antibiotics earlier, assuming everything looked good clinically?
I think it would make me feel more comfortable if he was on oral antibiotics until we had either some good signs of union or we had some problem with it. I don't know if the evidence really stands behind that. I think it makes me feel better that there's some suppression happening, but I'm not sure it's really going to have the kind of effect that I want it to.
Yeah, I agree, especially in anyone who's got some patient factors that lend themselves towards problems, whether that's social factors or diabetes or other immunosuppression and so on. I think we had some interesting questions coming in the Q&A. I thought maybe we'd try to hit a few high points here before we move on to the next case. Any thoughts on, I guess we talked a little bit about the antibiotic-coated nail as a definitive treatment versus the solid nail versus solid nail and some local antibiotics. Maybe a straightforward question for you, Dr. Learned, the amount of antibiotics that you put into your antibiotic rod that you created with the Ilizarov strut?
For me, those are a balance because I'm using that cement structurally, so I don't necessarily try to make that stuff super, super porous. So usually it's 2 grams of vancomycin in a 40-gram packet of cement and then 1.2 grams of tobramycin powder. So 1 package of cement, 2 grams of vanco, 1.2 gram of tobra. And then to make a nail, it usually, we'll talk about this with JKO's paper, but it's a chest tube, and because that metal rod takes up a fair amount of volume, then I think 1 or 2, I can't remember if it takes 2 whole packets of cement to make the rod. I think it takes 2, so I double that antibiotic.
Yeah, I do the same. I use 2.4 Tobra, but otherwise kind of the same technique. I know you were monitoring the questions. Dr. Learned, anything else that you think we should answer at this point before moving on?
The one question that I liked was the antibiotic-coated interlock nail. versus an antibiotic cement rod without interlocks. And I don't know if either of you have experience. I've done both. I find technically making an antibiotic coated interlocked nail tedious, but it is very satisfying to have interlocking screws and sort of have a definitive implant, but also having the protection of antibiotic elution. You have to use a really small diameter nail, and finding the right chest tube or suction tubing that's sterile can be sometimes a little challenging.
Yeah, and then you're drilling your interlocks after that's molded to reestablish the passageway for the interlock bolts, right?
Yeah, I'll use Kirschner wires while it's still wet. I'll drill them through. I'll mark the chest tube with the nail so I know about where I'm going, and then I use solid K wires that I put in while the cement is curing. And then oftentimes the canal or the cannulation of the nail gets cement in it, so you have to be comfortable putting in a non-cannulated nail. It just creates a little fuss, but it's a really nice technique.
Yeah, I think for this one, for as definitive treatment, if you are feeling a little wary about kind of the acute conversion, I think this is a great case to consider doing that. For me, if I'm doing an exchange nail for sure, then I favor doing kind of the quicker, more straightforward version that Dr. Levack presented here, where we're just trying to get a local antibiotic delivery device down the medullary canal. All right, I think with that, we'll move on to Dr. Learned's case. And let's get that going here.
Thanks everyone for the questions in the Q&A. Keep them coming. I think there's some really good points. Remember, we have to type and read and listen all at the same time, so try not to make them too long.
Dr. Learned has an infected pertroch proximal femur fracture that he's going to take us through now.
Great. Thanks everyone for being here. Thanks, Dr. Levack, for that case. So this is my patient. She's a 63-year-old female who was in Mexico and had surgery. Previously, she'd had the left hip done. Now we're talking about the right hip. She shows up in my clinic a few months post-op with right hip pain, and these are her x-rays. So at this point, this is a much different situation Dr. Levack presented, because now we've got a few months post-op. We don't have any sort of index procedure knowledge. She has an intact wound without drainage. And so for me, seeing this patient in clinic, we've got a few other problems. She's walking, not comfortably, but she is. And so this sort of—
what are the key questions you are asking this patient when they come in? What are the most important things you want to know? Kind of patient injury factors.
So I try to get a lot of history about the initial injury and then the initial post-operative course. So I like to know about, really how did it happen? Was this something that was high energy? Was this a trip and fall? Was this, was it an open injury? There's lots of things that are critical to sort of elucidating if there was some sort of problem early on, or if this is something that's developed later on. I like to know if they had problems healing their wound from the initial surgery. Oftentimes, there's some kind of key phrases that I like to look for. So the main thing with the history, I talked about open wounds, drainage, or if there's issues with their previous incision, if they were ever treated by their other surgeon or previously for this problem with oral antibiotics, and completely non-evidence-based. But in my experience, if a patient was told by their initial surgeon that it's only a superficial infection, it's about 100% chance that it's a deep infection. And then, so now we've got that. So history, we want to gather all this information, right? And obviously anybody with this kind of loose implant, we're clearly planning on intervening unless there's a medical reason why we couldn't, but we've got to
Dr.
figure
Levack,
out.
how about like patient specific factors? What else do you want to know about this lady?
Yeah, so, I'm looking at.
Dr. Levack, not Dr. Learned.
Oh,
Yeah, I think the host factors do matter. So I'm asking about medical history, diabetes, if they're on any immunosuppressives, are they on steroids? Those types of factors definitely play into things. Are they, how do they look? Are they emaciated? Do they have nutritional, this nutritional status to heal a fracture? So I'm looking at all of those things in terms of host factors too.
Yeah, and maybe add obesity and tobacco onto that list. But yeah, go on, James, with the kind of lab workup and what kind of things you think you can help.
So, yeah, so history, we have a long discussion. We talk about how this is staged. We've got to get a lot of information. Some of that information is only in the operating room, so we can't just get studies and magically figure out what's going on. When we're looking at the imaging, now we've got a non-union. So we have to think about if there's alignment, what kind of a non-union is this? Hypertrophic, oligotrophic, atrophic? What's their alignment like? Is there deformity associated with that non-union? Is that something we're going to have to correct in addition to the inability to heal? And then obviously sterility. Is this something that there's an active infection or something that's going to affect our ability to achieve that union? Lab workup in someone who is otherwise healthy and you may have an obvious recourse or an obvious cause. A lot of times the typical treatment is just lab values of CBC, inflammatory markers as a sort of baseline. But a lot of patients, especially if they're coming to you and you've never met them before and you're sort of trying to play catch up, looking at their metabolic status, looking at their albumin and pre-albumin, calcium, magnesium, phosphate, thyroid stimulating hormone, free T4. There's a large amount of laboratory data that you can obtain to sort of look at their nutritional status and getting an understanding if this is someone who is sort of malnourished or otherwise at risk for not healing, even in the absence of infection. So especially when your inflammatory markers are normal, those metabolic workup factors, vitamin D levels I didn't put on there, can be really critical in understanding that this may not be a bacteria or a problem causing a non-union. It may be truly that they just don't have the metabolic energy to get across the finish line.
Anything you'd add to that list, Dr. Levack?
I think that's a great list. There's also a really great paper by Dr. Brinker and his group that really highlights all of the laboratory values that you can obtain as a non-union workup. And it's really comprehensive, and it's one that I refer to frequently.
Yeah, so separate, I don't remember the year on that, but kind of classic article separate from the one we're reviewing later. The only main thing I add to this is a hemoglobin A1C, just to see that they don't have undiagnosed diabetes. So now, what strikes you as odd here, Dr. Learned? This is 3 or 4 months out. It looks like she's probably got some lucency around her implant, loose screw. I guess maybe tell us what her markers were and how you're trying to decide if this is an aseptic versus septic non-union, since she doesn't have the obvious signs of wound drainage and so on.
Her white count was normal, was 9.5. Her ESR was about 25, and her C-reactive protein was 2.5. So these aren't raging acute infection numbers. They're outside the normal range. There's a lot of so I think you have to sort of assume infected. But then there's a lot of things about this construct. I didn't recognize this implant. This isn't one I see commonly, but we know that proximal femur locking plates are sort of at risk for failure if they're not used in a very specific way, right? They need to be loaded and tensioned, and this looks like it's in varus, and it looks like things were just put in place. It doesn't look like there's any signs of an articulated tensioner or other signs that there is a lot of attention paid to the anatomical details. So I don't know if this is an infection problem, but it definitely puts me into a mindset of, I've got to go in, I've got to get rid of this implant. I'm going to have a lot of defects from the implants. I then have to take down the soft tissue around this non-union, and at the same time create a place that's, I want to have some stability. So this is not one where I feel comfortable just explanting everything, putting in antibiotic beads and taking cultures and then walking away. I feel like I've got to add something here as well. My typical go-to for a pertrochanteric fracture these days is a intramedullary device, just to allow for early weight bearing in this sort of frail geriatric population. She's not quite there, but medically, I'd put her physiologic age greater than her chronologic age.
Dr. Levack, anything that you would do in trying to determine, can I go in here one stage and just treat this as a kind of malreduced pending non-union and revise it versus knowing that you might have an underlying infection with these kind of labs that don't really steer us one way or another?
Yeah, I think it's hard to interpret the labs. It doesn't sound like from your history you had any obvious signs of infection, and it may be just that the implant was not applied, like you said, in the optimal manner. But in this patient, I think if you do a one-stage revision, you don't have a lot of real estate to do a lot of revisions and go back for an infection that is unrecognized. So I would be a little bit conservative with this and either consider taking a biopsy and then deciding whether to go all out with the fixation or plan to stage it and get cultures and take out the hardware and put in a temporary fixation.
Yeah, I think depending on the location, this is not one that you can kind of blindly stick a large bore needle in the office. I think sometimes that's an option to get a culture from the office without subjecting the patient to anesthesia. I agree. I think one option is, to just take everything out, send cultures. I would probably, like you said, be a little wary of relying just on like an intra-op fresh frozen as a definitive answer for this. So I think that's one good option, knowing that, hey, letting the patient know that, hey, we might be coming back just a few days later to treat the infection again, or maybe we can go forward with, definitive fixation versus doing everything right out of the gate.
Yeah, so for me, I agree with that I looked at this and, if she had just had a non-union and the fixation was still stable, I think I would be a little more open-minded to leaving that, do a biopsy or something like that. But given the dissociation of the implants, I knew that this was going to create as many problems for me as if I tried to save it as it would if I got rid of it. So moving forward, I elected to put in something temporary, and as I wanted to avoid the medullary canal if this was more infected than I thought it was going to be, or as infected as I thought it was going to be. So I wanted a screw and side plate device. I wanted something that didn't have a lot of moving parts and wasn't going to take out a lot of bone. And I wanted something relatively inexpensive because I was probably planning on taking it out in just a few weeks. It was not going to be, I don't want to put a huge locked proximal femur plate with lots of locking screws that's just going to go away. So for me, I used a condylar blade plate. So open debridement, cultured the metal, cultured the medullary canal, cultured the screw pathways, and then put in blade plate. Here we can see targeting. Here's using the chisel.
So lots of cultures, like 5 or 6 cultures, it sounds like there, Dr. Learned. And when you went in there, did this look obviously infected to you? Did you come across anything nasty?
Not purulent, no drainage, just lots of fibrous non-union, maybe a little more stringy and sloppy looking than normal non-infected fibrous non-union, but not gross purulence.
And would you have done something different if you did, grossly come across something that looked obviously infected to you?
Only in that I would follow that string all the way. So wherever it was purulent, I would go after that specifically, but I don't think I would do anything different as far as temporary stabilization, local antibiotics, IV antibiotics, cultures.
Dr. Levack, what do you think about kind of other initial options here besides the blade plate?
Yeah, in my hands, I don't know, I would have thought to do a blade plate initially. I think I may have tried an antibiotic intramedullary nail. It has a smaller caliber than a statically locked proximal femoral nail. And so it wouldn't take out as much bone, and potentially augmenting it with an external fixator as just a temporary measure to maintain some reasonable alignment while awaiting culture data and local antibiotic treatment, and kind of figuring out and planning for the next step, because this is a deformity correction that I would need to really plan for.
Yeah, and I think definitely if you open this up and it looked more acutely infected, I think, more strongly considering something, whether it's just a spacer in that lateral defect with the X-fix. Again, X-fixing a proximal femur isn't something patients are going to enjoy having, but just knowing that it's a temporary situation until we can get a better handle on the infection and how to eradicate that. I think that's a good option, maybe even putting some up some of the screw pathways. But as Dr. Learned mentioned, we're also have a real estate issue here in the proximal femur where we have to be thinking 2 or 3 steps ahead. We start putting too many holes in the proximal femur, whether that's, intramedullary nails or X-fix pin tracks, and we're potentially jeopardizing our fixation into that short proximal segment down the road.
Yeah, one of the participants actually asked about doing a 1-stage antibiotic-coated interlocked femoral nail if it didn't look infected. And I think that's a great point about real estate, because some of those interlocked nails have pretty large screws heading up into the neck and the head of the femur. And if you're planning a definitive blade plate, or if you're planning something else, you just want to think about, real estate in that area. What do you think about that, Dr. Learned, about doing an antibiotic statically locked nail in 1 stage here?
So for me, if I'm going to try to get a non-union to heal, typically, especially for something this one I would consider oligotrophic, I kind of fall back on my principles. And I think if I can achieve absolute stability, I'm more likely to do that. The challenge with a nail is obviously that we're not going to get that. So there's some anecdotal and early data on people sort of tension nailing, nailing with an augmented plate to sort of create that compression, but using a primary medullary device, or doing something like an osteoperiosteal flap, or other ways that we might reignite the fire of fracture healing. But I think if you just nailed this and you didn't do something about the non-union site, you're going to be pretty unhappy with the long-term results. I'm fine with the device so long as you're treating the fracture appropriately for that device.
How about coating your blade in cement, or putting a paste around the blade that's going in the head? Any thoughts about that here in the first stage?
Yeah, I've not tried coating the blade plate because the chisel and the blade are sort of match size, maybe dip it in something or you know, bless it with holy water sort of thing. I have, and I do like the idea of if you've got a previous cephalomedullary nail with a large diameter lag screw in the head, I will fill that pathway with either calcium sulfate impregnated with antibiotics or even methyl methacrylate impregnated with antibiotics to fill the void and deliver local antibiotics. I'm fine with the sort of Vanco paste technique from Tornetta and Fruzabadi, sort of, you know, mix it with a couple of drops of water and make it that sticky honey consistency, and then you can sort of stick it to anything. But I don't think you can use it over the actual blade portion because it'll get squeegeed off as it enters the blade tract.
Awesome. Now this, Dr. Leonard, so we're moving to a blade. Dr. Levack mentioned, you know, kind of this is classically a pretty complex planning operation. We've already lost a little real estate in the head from the previous proximal femoral locking plate. So how are you planning this surgery? Are you, you know, plotting your blade here and templating this out with the anticipation that this is your one chance and this is going to be your definitive way to treat this both temporarily and definitively, or do you kind of have a plan B as well?
Well, it's a good question. I think so. I was fortunate enough to have a few mentors who were old enough that this was this thing I saw frequently in residency. And what I love about the blade is that it's got a very different entry point than most of our common sort of contemporary implants, whether that's a sliding hip screw type device or even a cephalomedullary nail. So when someone's had another device, usually the blade goes in somewhere different. It's also a really bone preserving device, right? It creates this U-shaped channel, but you don't take any bone out. You don't drill any bone out. All you do is remove the tiniest bit from the lateral aspect of the trochanter to accommodate the shoulder. And so I'll use this because my initial thought was kind of like our participant asked, my initial thought was definitively this lady's getting a CM nail. And so I want something that's not going to burn my start point, not going to burn my lag screw start point, and won't contaminate my canal, so that I can put a bunch of antibiotic beads into those areas. I can hold this femur reasonably stable, and the blade I can put it in to a spot that's going to be sort of not where the screws were and not where the screws are going to be. I'm not necessarily going at this operation. You can see on the lateral view that I've not corrected some of the flexion deformity or apex anterior deformity to the right. I'm a little posterior in the neck. So this is not the Jeff Mass school of blade plates. This is, I'm putting a blade in to preserve things because it's a relatively simple implant. It doesn't have a lot of areas where I think infection is going to hide. I can add a lot of antibiotics to the wound, and then I'm going to go in later and remove this plate and not feel bad that I spent $2,000-3,000 on an implant that lived in her for a month. I'm going to go in and take this out and do something definitive for the fracture itself, the non-union.
So at this point, you're still thinking the blade's coming out and you're putting a cephalomedullary nail in as a second stage.
That's correct.
Awesome. Carry on.
Great. Okay, so here's my device. I've got a little bit, you can see from this, I've got almost exactly 90 or maybe 85 degrees from my diaphysis to the blade trajectory. And that way, when I put in my 95-degree blade, I've got a little restoration of what looks to be a little more normal anatomy on the AP view. I still have what I pointed out earlier, the apex anterior deformity, sort of extension deformity at the fracture site. But this gets me starting to look like I've got a femur that could be treated with pre-contoured implants, be that medullary or extramedullary. One of the challenges is this is not a locked implant, so I've got to have enough screws to get good enough friction fixation, because this is an old implant that goes back before the days of that. And then I'm also going to add a bunch of, in this case, resorbable calcium sulfate beads. You can see that they are under and in front of the plate, as well as throughout the rest of the wound. And so this is stage 1 for me. And then
you have Vanca and Tobra in there?
Yeah. Yeah, and then with these beads, these are commercially available. You mix the powder with either sterile water or with liquid Tobra, mix in the Vanc. They make little beads of varying sizes. You can sort of sneak them in anywhere. Problems with calcium sulfate, I find even with the sort of newer generations, we do still have some drainage issues. So getting a really good closure is important, and then having that conversation with your patient and with your nurses or residents that, hey, we expect this to drain, so that's not a problem. It's part of the course we'd expect. So here she is at day 0 from my intervention, and I don't have her deformity perfectly corrected, but I do have her old implant out. I've got lots of cultures, and I have enough stability and deformity correction that I've started to get her where I'd like to have her in the long term. So now she comes back, she spends a day or 2 in the hospital. We get her IV antibiotics started. Her cultures grow coagulase negative staph, so MSSA, excuse me, not SSA, excuse me, staph epidermidis. She gets treated with 6 weeks of antibiotics. She gets serial inflammatory markers during that entire 6 weeks. And then at this time, I was still doing a little bit of voodoo, which was, okay, we stop the antibiotics, we give it a couple of weeks for those antibiotics to completely be washed out of the system, and then we check your inflammatory markers again. And the idea behind that was saying, okay, if your antibiotics are off and your markers stay low, then we'd assume there's no more causes of inflammation, using that as a proxy for infection. But if they're still high, then maybe we need to do something. So now we get more labs and we got to make a decision, but we don't have good evidence to support that. So is that something where are you guys using serial inflammatory markers after treatment to see effect? Are you just going from clinical gestalt? I'm curious because I've stopped doing this personally.
Dr. Levat?
At this point, at the stage that I'm at, I like to have more information. So I tend to stop antibiotics, get a repeat set of inflammatory labs, and if they've gone up, then my anxiety goes up and I'm more concerned. And if they're steady, then I have a little bit more reassurance that maybe we're out of the woods. And there's no data to really support that. And it's really probably just treating me, but I'm still doing it just to see what the trend is.
Yeah, I mean, I tend to still follow them also. I think when you have a patient who, correlates well clinically with the markers, then that's really useful. So somebody who comes in, with a SED rate of 80, and a CRP of 15, and it goes back down, to low normal after their debridement and their treatment. That's somebody who, I think is more useful, again, just gestalt to do this sequence of checking them again. I mean, this patient, has had an indolent infection brewing in there for quite some time, as a kind of equivocal SED rate and CRP number. So when they come in that situation, I don't put a lot of weight in them, because now we've likely caused them to go up just from the inflammatory insult of surgery. So then they might be higher initially than they even were at presentation. And so I agree there. I do still check them. I think it's just part of the overall package and kind of your clinical interpretation of, your findings, how well you think you adequately debrided and aggressively treated this infection with local delivery. So it's part of the picture, but it isn't something I hang my hat on, I guess.
Yeah, so, you know, I think what we love, and I agree with both of you, that we love to get information and try to make decisions, informed decisions, right, with information. And so when I saw this, I said, okay, well then this is sort of the part on the flow chart where we go back to the beginning and we do the same thing. So we're going to go back, we're going to take this implant out, we're going to take more cultures, then we'll give IV antibiotics, then we're going to, you know, re-debride and look for something that I missed last time. And then if we think that this is sterile and we're going to proceed, then what sort of a revision implant you would use for a definitive implant? If you think you're going to revise it for another round of debridement, what implant would you use? And I sort of fell into the same, I don't want to say trap, but the same mindset as before, that, you know, this kind of worked well for me. So I took out her implants, cultured the implants, cultured the blade tract, cultured the wound, and then going really aggressively.
Just to go back to a second so everybody's clear, her inflammatory markers were higher even than at presentation at this point, or they had somewhat normalized, or where were you at with that?
They were closer to normal. I'd have to double check her numbers. I think they were slightly elevated from her lowest numbers during antibiotic administration.
Okay.
So they had slightly crept up. They were out of the normal range. So I took that, especially since I wasn't a part of the initial surgery. I just felt like there was a little more to do. So went back to the operating room, took out all the metal, and then went really aggressively at the non-union site this time, thinking that the last cultures were methicillin sensitive. It was not a Staph aureus. So, you know, this is not a super virulent.
Let's back up to that for just a second. I wanted to talk about that. So just to be clear, this is coag negative staph, not staph species. So usually that staph epi can also be staph something or other, starts with the L that I can't pronounce. But those are historically bad actors in biofilm, you know, production. So Dr. Levack, any other bugs you would add to that list that, as Dr. Learned said earlier, makes you want to vomit and get a glass of water when you see it come back on your culture, you know, on your culture results, or kind of changes your approach?
So the coag negative staph does tend to form biofilms readily. The other organisms that make me cringe are just the multi-drug resistant ones. So VRE, I've had a lot of trouble getting rid of that. And you know, any of the multi-drug resistant organisms where you just don't have a lot of options, just really make me nervous.
Yeah, polymicrobials, and I think the Pseudomonas also, when you see that in a mix, usually with a polymicrobial infection, you know, then you've got biofilm plus polymicrobial infection, which bums me out. So got it. So James has made the decision to go in and do everything at once. Ashley, do you agree with that? Would you have considered doing an open biopsy at this point, or getting any other information, or you also feel comfortable knowing Dr. Learned has done an aggressive debridement and everything has been fairly quiescent here, and she's had a, you know, local antibiotic delivery with beads, a 6-week course of IV antibiotics?
Yeah, I think you have to kind of trust your own judgment on that, and what you've seen and what you're seeing clinically. If you feel like you've gotten a good debridement, if you feel like you adequately were able to assess the fracture and get the debridement that was necessary, I think it's very reasonable to proceed like this. You've treated the infection with antibiotics, both locally and systemically, for a reasonable duration of time. If you are concerned clinically, or if you're concerned about the inflammatory markers, I think it would also be reasonable to get a negative culture before proceeding with definitive treatment. And that's a really hard decision to, whether or not to do that. I think it just depends.
That's where, the markers aren't great, but, if she's off antibiotics and her SED rate was 18 and now it's 90, then that, maybe makes you favor the repeat debridement, hardware exchange, some of those kind of things before going to something definitive. But I think this is still really an art of medicine. I think it's really hard to study all of these issues, and I think you could present these cases to 10 equally great surgeons as you guys and get kind of 10 different kind of pathways or answers. So I think as long as you're trying to stay one step ahead and you're being thoughtful and mindful of these issues, sometimes it's just time to take that leap of faith if you feel good about it, as Dr. Larned has done here.
Yeah, and what's interesting about this is I approached this operation as maybe the primary goal here was debridement. It was actually to address infection, and to say I'm going to prove to myself that there is no infection here, because right now I think there is, because she's got these mildly re-elevated inflammatory markers, and I know that I had always planned stage 2 for this. And so this was actually it was following the plan. It's just that we're not quite to the point where I felt comfortable doing stage 2. I wasn't comfortable putting a nail, doing an osteoperiosteo flap, or bone grafting this. I still worry about infection in this scenario. So this was really addressing those inflammatory markers, and I didn't feel ready to go whole hog into non-union repair here. So I went aggressively for debridement. I said maybe some of the sclerotic bone along the fracture site is causing me a problem, and then maybe the fact that I don't have medullary continuity with that fracture site is creating an issue where there's either something hiding or where I'm not getting IV antibiotics. So this was really a debridement. And if I happened to get union with this operation, that was just icing on the cake. For me, this was more information gathering, more debridement, more chance at treating infection. So this time I was a little more careful with her alignment. I was a little more careful with my blade passing and changing things. I debrided more aggressively. You can see the articulate tensioning device. I'm actually compressing it this time, and then going on to have more contact. I still on the lateral view. I'm a little out the back. I have a little that apex anterior deformity given the bone loss that she has, but I've added another screw into the proximal fragment. I've translated the shaft in a different spot. So I'm trying to set this up for deformity reduction and getting compression across her fracture site, in addition to all the cultures that I took.
Same blade length or as your last one?
I believe it's the same blade length of an implant. We did after the debridement, I think I was able to seat this one further. So this was another aggressive debridement. I did more work to take down the sclerotic margins of that non-union and establish medullary continuity. And then I created a more favorable fracture environment. This is where the question about a short CM or a long CM nail, I would not be able to do that with that implant. And then you can see my antibiotic loaded calcium sulfate beads here. So again, I'm treating the instability issue and the infection issue first, and I'm trying to get my deformity better so that if she happens to unite here, I'm not going to be creating a mechanically poor hip.
Yeah, certainly. I think, this location is just nice because you've got a robust soft tissue envelope. So I think it gives you a little bit of forgiveness here to do something that, provides this level of stability and compression versus, say something around the ankle or something where you might be more wary of putting a surface implant back in, for example.
Yeah.
And her
And so-
cultures at this debridement, were they?
More cultures were taken. She did not grow anything from these cultures.
Nice.
She had been off antibiotics for about 8 weeks at that time.
Yeah, I think this is like the tibia that Dr. Levac puts the antibiotic temporary rod in and kind of disappears for a few months and then comes back, and they're healed around what was supposed to be a temporizing measure. It's awesome when this happens, and I think it's a credit to kind of the thoughtfulness and the technique of using the blade and getting the compression and stability at the fracture site, and still doing the appropriate attention to principles and details in terms of the aggressive debridement and reestablishing the medullary canal that I think tilted this lady's factors as far as surgeon factors in her favor.
The other thing is that in her follow-up at 3 months, we talked, and I said, look, you got normal markers, you've got cultures are negative. If you want to have another surgery, I'm willing to do what I always thought would be our last thing. However, this is looking pretty good, and if you're willing to ride it out with this, there's enough callus on here that I'm willing to try it, because if it doesn't heal, I'll nail it. So in this case, she and I spoke together, and we decided, based on how she was feeling, and I started to let her weight bear at about 3 months, that she was feeling good. And at 8 months, she felt great. And at 18 months, you can see she's really consolidating nicely, and she's come back, and she's got great hip motion, and she's very, very happy. These plates can be symptomatic in the greater trochanter, so I'll offer people implant removal if they're interested in that. And she has no interest in having any more surgery.
And sorry, what was her length of oral suppressive therapy, or I guess what was her overall antibiotic plan with the second surgery with the negative debridements? Did she go back on IVs or not?
We used empirically. We used, I can't remember which one we used, but it was probably ceftriaxone, or it may have been something else, or maybe Unison or something that was empiric for the staph epi. And then once the cultures were negative, I think the ID docs put her on that for maybe 3 weeks. And then when cultures were negative and they had done that, we chatted. We both decided to stop them based on negative cultures. And I don't think she went on any PO.
Yeah, and I agree. There's not a lot to guide us on those decisions. I think good communication with your consultants is obviously really important. I think the coag negative staff would make me nervous about not running a little bit longer suppressive course on this, but agree that I wouldn't keep her on these for 6 months or something till she was healed, although I don't think that's an unreasonable decision either. Dr. Levac, any additional questions or thoughts on this one?
I agree with, going by the negative cultures. If you've felt confident in your debridement, that you don't have to suppress until healing. Looks like she had a great result, mostly as a result of surgeon factors.
Yeah. Any thoughts? Just a few things on the Q&A about early weight bearing, with different implants, whether that's an initial antibiotic coated nail at the first surgery, Dr. Learned, or using a cephalomedullary nail as you initially planned? Do you think that helps them heal if you let them walk on that earlier than the 3 months she was kept off of the blade here?
Yeah, I think it's just a balance, right? We're talking about infection issues versus mechanical issues. And, she had come to me with this issue where she'd been hobbling around, and you can see that she's not a skinny lady, so she's got a little bit of weight to her. So you can definitely get earlier weight bearing on a medullary implant. I was hesitant to do that when I thought there was active infection. I don't love the idea of putting a medullary implant with active infection, especially with something like a cephalomedullary nail where there's lots of moving parts and other things with some of the newer designs, places where I don't think I'm going to get good antibiotics. I just worry about the complexity of that. And I don't have a good bailout once I start taking all that bone away. So I wanted this until my infection was eradicated, personal preference. I think it's possible. It just, you create a different portfolio of challenges if you use a cephalomedullary device early in this lady.
Great. I think in the interest of time, we'll progress. Just wanted to maybe underscore, continuing to think about patient factors that you can optimize during that time. So if this is a diabetic, really harping on them and their diabetic team to try to get their diabetes under better control, smoking cessation. I'm a big fan of even exaggerating the increased risk of infection and non-union to smokers. There's some decent evidence that we're pretty good at kind of scaring people into stopping smoking, especially when they're facing a complication already. Vitamin D, thyroid, and then, even this obese lady often will have major malnutrition issues, so trying to get them on some protein supplements. Anything quickly that you would add to that, either of you?
Only that it turns out that probably smoking more than nicotine is the problem. So even if they have to go to nicotine supplementation, it's probably a move in the right direction.
Yeah, patches and gum are better than cigarettes for sure, I think. All right. We are going to proceed on to the Journal Club portion here. I wanted to just, give the audience a second to take some notes. And I would remind everybody right now that tomorrow night, this recording will be up on the AO NA YouTube page. So if you don't have a chance to write this down or remember it, this is just a nice technique paper on how to make a antibiotic coated nail using the Ilizarov strut and a chest tube and hand mixing cement. So pretty basic materials that most folks would have access to. This is, I think, also worth looking at. This is the working group, mainly through the AO, on defining fracture-related infection. A lot of the things that we talked tonight about, some of the obvious signs, but other ways that we're defining this when you're thinking about a treatment protocol for your patients. And then I'd like Dr. Learned to hit some high points on this very recent Dr. Brinker article, again, separate from the malnutrition article from a number of years ago, from March 2021, on the utility of biomarkers for diagnosing infection in non-union. And I'm just going to bring the abstract up for people to peruse while Dr. Learned is summarizing for us.
Great, thanks, Tom. So this is a great paper. It's a series of patients from this private elective practice, non-union centered. And this series is 204 patients with 211 non-unions. They wanted to look at, like Tom said, they wanted to look at what is the utility of these biomarkers, right? So we all talked about getting ESR, getting CRP, white blood cell counts, and using that to make decisions. So they said, are these good markers to use for decision? We all use them, but are they actually useful? So they took all these patients and they categorized them into their clinical impression of infection, having nothing to do with laboratory markers. And then they got inflammatory markers within 2 weeks of their surgery. And then they would do an intraoperative biopsy and tissue cultures, and that's either open through the fracture site or reamings for a medullary approach. And using the Musculoskeletal Infection Society and the AO Working Group for Fracture-Related Infection criteria, the criteria for infection is you have to have 2 or more positive cultures that grow the same bug. So in Dr. Levak's case, you had 5, so you definitely qualified. 1 culture that's positive suggests infection, but is not diagnostic. And then a draining wound or an open wound is diagnostic of infection by itself. This was of these 211 non-unions, including 1 patient who had 3 non-unions that they operated on. There was both upper and lower extremity, and the majority, 80%, were oligotrophic or atrophic. And they had 40%, 40 cases, 19%. They had 34 cases that were 2 culture positive, and they had a draining wound in 6 of them. Of note, 18 out of 40 were tibia. So the overwhelming majority of their cases, or plurality, were tibia. When they looked at the data to follow how the presence of infection based on culture and draining wound correlated with ESR, CRP, and white blood cell count, really it was almost a 50-50 shot. The diagnostic accuracy of these was extremely low. Whether they were used as dichotomous variables, meaning they were above normal limits or within normal limits, or as continuous variables, just looking at the absolute true value of any of these numbers, they were still low diagnostic accuracy. So the odds ratio is between, I think, 1.4 and 1.8, or 1.1 and 1.8, 1.07. There you go. So really, these aren't great labs. We don't have something better. And if you look at anything that Dr. Parvizi's done, you can see that we're looking for better markers for infection, whether it's prosthetic joint relation or fracture related. And we just don't have good labs. So we use them, but the actual scientific basis for this data is probably not as good as any of us would like it to be.
Yeah, I think there's a really nice discussion in this paper. Encourage people to pull it, that really compares their findings with 2 other papers that were more, I guess, enthusiastic about the negative and positive predictive values on these markers. And as we talked about with these cases, they're still a part of our practice. I still view these as, negative results don't really help me a whole lot. Those low normal don't help me a whole lot. I think somebody who comes in with sky high markers without another explanation, with another, otherwise benign looking wound, is a red flag for me, even acknowledging that the positive predictive value, at least in this paper, isn't all that helpful for these, but certainly ripe for more study. With this is I think about as good as you can do from a single hospital, over 200 cases here, but still with only 40 infections. As we always say, more patients, more centers, larger numerators and denominators would help us with this. But I think a really thoughtful paper, and again, the discussion I think is great for those that get a chance to look at it. I encourage you to read that.
Yeah, and the incidence of infection in the other series was in the 30 and even up to 80%. So we're looking at there's a huge selection bias, and when you're getting that the low incidence changes the power of a study like this. So what I think this shows me is these are not the be all end all, and so it's one of our tools, but we shouldn't rely on this to make the diagnosis for us.
Yeah, certainly this is not a pediatric septic hip where we can hang our hat on, having all three of these come back high or low and feel confident that we're ruling something in or out.
Yeah, I think that's a great comparison to sort of how rigidly we can apply this data.
Dr. Levack, any other comments on the paper here?
I think that was a great summary. I agree with everything that you said.
We're going to try to get everyone done here right on time. So just in summary, I think looking at these cases, this is the way, I think of this, and I think was reiterated during the cases of just, assembling all of the information. So having the injury variables, especially, both of these cases were done at outside facilities and came in and trying to get as much information as you can from the records, outside surgical notes, previous labs, at least information from the patient about, how did this happen? And as Dr. Learned pointed out nicely, were they treated for a quote superficial infection at some point? Then looking at the surgeon factors, both with the index surgery and, really planning your temporizing and definitive surgeries and having, plan A and B in place here, and then trying to push any patient factors in particular into your favor. The hallmarks of treatment are aggressive debridement and cultures, providing stability while the infection is being eradicated, and then antibiotic delivery should be local and systemic whenever possible. So really appreciate everyone. I know we have a lot of international folks on tonight. I do think that we at least touched on everyone's questions that I saw. All of us are easily Googleable. So if you didn't get your answers or your questions answered, please don't hesitate to reach out to us. Just a reminder, we have another 6 great firesides coming up over the coming weeks. The schedule is here, and I think everyone's probably getting the reminder emails from the AO, so encourage you all to tune in. And also as a reminder, all of these are available for free on the AO North America YouTube channel, which I think is just a tremendous resource, not only for the firesides, but a lot of other great educational materials. So with that, I think we'll sign off. We do have a very important evaluation for you to complete before you sign off. So Chris is bringing that up right now. We really appreciate you just taking a few seconds to answer a few questions about tonight's session. Thanks so much, everybody.